has been, so just for 2 minutes. So Rahil has been in US for, almost about 7-8 years. He did his undergrad at Wharton Business School, and then he worked for some time at Microsoft. But then he decided wisely to join and come back and take reins on NM Medical. So he's been here now almost for 12 years. So to be honest, he's now is more than a doctor. I mean, if you work in a medical center and do in and out for 12 years, I mean, you really understand the things much better. And also being an advantage that you have a good education as a background, and then you don't have to have medical responsibility to day-to-day look up the patients. That makes you much more wiser and much more broader in overall applications of the different things happening in the medicine, which is very, very difficult for any particular doctor to keep an overall view of multimodalities. So that's it. And I think I'll put on to Rahil. I mean, more than me, Rahil is not slept for more than 5 hours. That I can say you, or maybe not for slept for 24/7. It's very difficult. His life has been extremely difficult, particularly in this crisis day. And we do understand people anxiety. So we're trying our best to really satisfy them whatever best we can do within our norms. So over to Rahil.
Thank you. Good afternoon, everyone. It's a pleasure to be here as a fellow Rotarian and have an opportunity to address the club and answer whatever questions or queries you may have around the current challenging situation that India is going through with COVID, and also any questions related to testing. So I'll spend the next 20 minutes or so running through our experiences with COVID, where we are today, where Bombay is primarily today, a little bit about the country as well, and then we can open it up to questions. So this talk today comes at a time where India is going through the worst wave of COVID that has been seen globally anywhere since COVID broke out. I think almost everyone on this call would know of or be in touch with a household that's affected by COVID in the last few weeks, particularly this second wave or second strain that's been hitting India so badly. And every day when we switch on the television, open newspapers, they're splashed with horror stories of the way the pandemic has really ravaged the country. Global media has not been kind to us as well, and you see stories of India being portrayed across all global media networks, be it The Economist, CNN, BBC. So India is going through a tough time. The perception of India globally has dropped as well significantly in the last few weeks. And it may be a case of waking up after the horse has bolted, but we really need to get our act together to ensure that the country never experiences something like this ever again. Just to give you some context, at NM today, we're doing every type of COVID testing, ranging from PCR swab tests, antigen swab tests, antibody blood tests, CT scans of the chest, and all the COVID inflammatory blood markers that need to be done to monitor vital parameters of a COVID patient during COVID and post-infection in some cases as well. I'd like to start by talking about the first wave that hit us last year and how the current wave differs. I think that will give us some understanding of the challenges that we are faced with presently. So when COVID first broke out in March, April last year, we saw a gradual rise in the number of cases, a gradual increase in the detection rates as testing was made more liberal. Testing policies were changed such that labs could test without doctor prescriptions. Anyone who wanted to walk in for a test could eventually walk in for a test. The local wards and DMC understood that it's wiser to invest in tests and have that data go out than try to suppress it and hide it from the rest of the country or rest of the world, and in the process have the virus spread without any control. So as we progressed through June, July, August, September, while the cases were rising, there were a few comforting factors. One, deaths continued to remain low. The initial fear and stigma that came around having COVID slowly disappeared. People became more accepting of the fact that, okay, COVID could be dealt with like any other viral infection. And as hospitals and doctors became wiser to treatment protocols, treatment drugs became more readily available. India learned how to tackle COVID. So I would say on all four fronts, whether it be the psychological perception of getting COVID and the fear of associated with it, managing testing, managing hospitalization, and managing treatment, India did a very good job. The BMC and the countrywide authorities were quick to act in setting up COVID quarantine centers. Beds were made available. Resources were mobilized to quarantine people effectively. And come September, October, we peaked at a level of about 2,500 cases a day. And we had capacity to handle more. We had capacity to handle more critical cases as well. ICU beds were available. So as cases started to decline in the October-November timeframe and flatten out from December onwards, it was not unreasonable for people to think that India had escaped the worst of COVID. Perhaps for once we could boast about and be proud of the fact that we were ahead of the Western world. Hearing about what was happening in Europe and in the US, India had seemed to have gotten away very easy. And there were a number of theories floated for this. It could be some form of genetic immunity. It could just be that the strain that came to India was a milder strain. It could be that India was more proactive in dealing with COVID than most of the countries in the Western world, in the way we implemented our lockdown, in our testing policies, and so on. So whatever factor you put it to, it was only to be expected that when the year ended and 2021 started, after 9 months of lockdown and restrictions and people not being able to travel or go to work freely, it was only expected that things would open up significantly in the months to come. So as Jan and Feb rolled around, a lot of restrictions related to COVID were relaxed. Social distancing was relaxed. Large get-togethers were allowed. Travel was opened up. You could host weddings with 500, 800 people. We tested for many weddings, that had that many number of people attending the wedding. And positive rates, which were in the 15% or so range at the peak of infections in September, October of 2020, had now dropped to about 3 to 5%. Okay, so certainly manageable. Labs scaled down their testing capacity, started focusing on other non-COVID areas which were neglected during COVID. Hospitals started admitting patients who needed care, who didn't really get that care when COVID was at its peak in the first wave. And the BMC quarantine center started rolling down. We heard about a quarantine center that was built next to an SAI dome in Worli with a 600-bed capacity, and that never got used. It was shut without getting used because COVID had come under control. And the other big development in that time frame was that vaccines were made available. So there was a lot of optimism, much to cheer about. And for all practical purposes, we felt that the battle was won. The health minister declared that, the prime minister declared that, and you could see that in the way India was opening up to mass gatherings. Little did we know that there was a nightmare around the corner. And perhaps we should have been wiser, hearing about second waves in the Western world, hearing about what was happening in Brazil, which had relaxed its restrictions perhaps too early and went through hell similar to what India is going through today. But we did not. And in early March, we started to hear about a sudden surge in cases in the rest of Maharashtra. So we have a center in Pune as well. And we started to get feedback that suddenly there's an overwhelming volume of COVID cases, CT scans and PCR tests coming forward. And before we knew it, in the next 3 or 4 days, the same happened in Bombay. Okay, so we were hit by a wall of COVID unexpectedly, with an exponential growth that no one could have predicted or no one could have foreseen. And suddenly we went from having a few hundred positive cases in the city a day to about 10,000 positive cases. Very frightening, very worrying. And let me identify a few trends that were very different in this surge of infections as compared to the first wave. In the first wave, mostly we saw the people who were getting infected were domestic health, drivers, and elderly patients. Those who got sick were people who were either elderly or had pre-existing comorbidities, and they were the ones who required hospitalization. In the second wave, it was very different, and it is very different today. This wave of the virus is far more virulent, which means it's far more severe in its manifestation of symptoms. It's far more transmissible. So in the first wave, typically we would see one member or two members of a household being infected, but it didn't mean that the whole household got infected. With this wave, if one member gets it, you can almost be certain that the whole house is going to be infected in days to come. And this wave of the virus is affecting every demographic, whether it be young babies, young children, young adults, and the elderly. It's also hit a far more affluent section of society. So it's not just domestic help anymore. We see a lot of middle class and upper middle class, the high-rise population of Bombay now severely affected with COVID. And a lot of them require urgent medical attention. They require hospitalization or they require critical care at home. And we weren't prepared to deal with a wave of COVID like this. Even if we expected COVID to come back, we thought it may come back in a similar form to what the first wave was, not this super transmissible, super virulent form of COVID that we've been hit with today. And as a result, testing labs, quarantine centers, hospitals, medical professionals, all were caught completely unawares. The government was caught napping, whether it be state government, central government. Let's not get into the politics of that. The fact remains that everyone was left unawares, and to be fair to them, no one could have predicted this coming. So what's going on? Why have we seen, or what kind of virus is this that's creating so much pandemonium? So it seems that in the months prior to March, when the virus was kind of left unchecked and our testing was relaxed and social distancing was relaxed, the virus mutated into various different forms. So the original mutation that was there in wave 1 was no longer causing mayhem. But these newer mutations that formed in the January-February timeframe slowly started spreading through the country. And through mass gatherings started spreading to individuals from house to house, office to office. And suddenly we have 2 or 3 new forms of mutations in India itself that are now prevalent in the country. Additionally, a lot of global travel that came into the country brought in new mutations from the UK, from Africa, from Brazil, from the US. So a combination of these, I believe today I read an article in the Times of India stating that there are 10 mutations globally currently circulating with COVID. And India seems to have all 10 in some form or the other. So that's really been the big difference. These mutations are beating antibodies. So we're seeing people who were previously infected with COVID getting reinfected. The mutations seem to be beating the vaccine-generated antibodies as well. So people who have had 2 doses of the vaccine, few weeks post the second dose as well, worryingly enough, are getting COVID and are getting symptomatic COVID. Now, there is no way to know if that vaccine shot at least prevented the person from ending up in a hospital bed. We don't know. But the fact remains that certainly the vaccine is not protecting people from getting the virus and getting the virus with some form of symptoms. So the takeaway message really is that unless you have a large enough percentage of the population vaccinated and a large percentage of the population being tested whereby they can be traced and tracked and contact tracing can be done effectively for them, the virus will continue to grow and mutate. And when that happens, eventually those mutations are going to cause the kind of mayhem that we're seeing in India today. If you see the UK, if you see Israel, perhaps the US to some extent, these are examples of countries that have had a good penetration of vaccination in their countries and a good amount of testing. And we're seeing the results today. There may be a third wave or a fourth wave to hit these countries, but it's probably not likely to be as ferocious as what we've seen in India, because there's a large enough percentage of the population that's vaccinated and people are being tested at a large enough scale. So let me change track here and come back to the testing piece again. So, and I'll try and throw some light on the different types of testing, what India is doing today and where we should go in my opinion. So, like I said, there are 5 different types of COVID tests that are performed in the country today. The first, the gold standard, is the PCR swab test, which is a nasal and an oral swab. The sensitivity of that test, which means its ability to correctly identify a person with a COVID infection, is about 95 to 97%. And therefore it remains the gold standard. That is on line with any other tests that we can do for viral infections across the globe. The challenge with PCR testing is it it requires some expertise to collect the sample. It needs to be collected in a special medium. It takes time to transport those samples to the lab. And then there is some time taken, a few hours, to extract the DNA and actually process the sample, right? So the entire process from collecting a sample to running it, depending on how far the collection site is from the lab, could take, in a best case scenario, 5 to 6 hours. And in a worst case scenario, like we're seeing today, 3 to 4 days, depending on what kind of a backlog of PCR there is in the lab. The second test is an antigen test. The antigen test is just a nasal swab test. So in PCR, you have both nasal and oral. The antigen swab is only a nasal swab. The antigen test is run on a card device and can give you a result within 10 to 15 minutes. Once the buffer solution is loaded on the device, we can see whether the patient is antigen positive or negative. So that's great, right? I mean, imagine to be able to get a result on the spot at a patient's collection site in 15 minutes. So what's the problem? The problem is the sensitivity of an antigen test is only about 70%. So which means that 1 out of 4 infections or 1 out of 3 infections potentially can get missed, and that's very dangerous. Today, ICMR says with the current wave of COVID that's going around, 1 positive patient in a period of 1 month can infect 406 people. So imagine the price of missing out a COVID positive case. 406 people is through a chain of contacts is what 1 positive patient can potentially infect. Okay, so the antigen test is a good substitute for PCR in areas where PCR testing is not available. Maybe for large factories in remote areas where workers need to be tested on an ongoing basis. Buildings where laborers come in and they need to be tested on an ongoing basis. There is a cost advantage to antigen as well. It is cheaper than the PCR test. So certainly that's the other advantage that one can look at when deploying in large volume. The third test is the antibody test. So the antibody test is a blood test. And effectively, there are few varieties of this antibody test. But the 2 main ones that I would like to focus on is post-COVID antibodies and post-vaccine antibodies. So the post-COVID IgG antibody test quantifiably assesses the presence of protective IgG antibodies against that particular strain of COVID that one was infected with. Now, that may not protect, like I said, against future strains, but it certainly reduces the likelihood of someone getting reinfected if they have protection against some strains of the virus. So that's one test. The other test to look at is post-vaccine. So post-vaccine, neutralizing or spike protein antibodies get generated in the bloodstream. And these can be quantitatively measured maybe 4 weeks after the first dose, and again 2 or 3 weeks after the second dose. And one should see a rising trend in the values of the antibody titer. Not every lab is able to run this test. So when you do the post-vaccine test, you must insist on a spike proteins post-vaccine antibody test. The test must be able to measure spike proteins, because if it doesn't measure spike proteins and capture some of the other types of antibodies that one gets post-COVID, it will not be able to detect the post-vaccine antibodies. Now, I'm really surprised that the government has made no push to get antibody testing done at scale. Even in the first wave of COVID, when antibody testing was available, there were some efforts made to do serosurveillance, but they were at a very small scale. Today, I would imagine that antibody testing, even more than PCR and antigen, is critical for each and every individual to do post-COVID and post-vaccination. So we get a clear sense of what kind of potential herd immunity exists in India. The only reason I can think of for not pushing it in a large way is that we don't want the numbers to go out on how many people actually have been infected with COVID in the country. Otherwise, logically, antibody testing should be out there in a huge way. I would encourage all of you to get antibody testing done for you, your family, your house help, and your office staff. The next test is a CT scan of the chest. So this is a very simple 1-minute protocol, almost like doing a chest X-ray. And essentially, because COVID affects the lungs as a viral pneumonia, the CT scan of the chest is able to identify if there is any lung involvement for a COVID positive patient. And we're able to quantify that involvement. So there's something called a CT score, which is different from the CT value that comes with a PCR report. Okay, so people kind of tend to mix the two. CT value with a PCR report is an indicator of contagiousness of the individual who's detected as positive. Okay, the CT score that comes with a CT scan of the chest is essentially just a scoring of the lung involvement. And for patients who have significant lung involvement, they need a particular form of antiviral drug to be given to that. So that's the value of doing the CT scan. It doesn't need to be done for every patient. The clinician is perhaps the best person to make a judgment call on whether a CT scan of the chest is required or not for a COVID positive patient. In a few patients, a good number of patients maybe, the CT scan of the chest would probably need to be done in a serial manner over a period of a few months to follow up on resolution of the lung involvement. Okay, so this morning on one of our radiology groups, we had a case posted of a COVID positive case, CT scan of the lungs performed with a 1-month interval for the patient again. And the patient had a lung cavity that resulted from the COVID pneumonia. So in some cases, one may need to continue to do the CT scan for a period of time. In other cases where there's low lung involvement, a one-time CT scan would probably be enough. And the last piece that is done in good numbers is the blood work related to COVID testing. So all the COVID inflammation markers. COVID is one disease, the reason why it's so worrying is it's a multi-organ disease. It's one disease that can cause havoc from head to toe. And we're seeing post-COVID complications globally in the brain, in the heart, in the lungs, in the form of blood clots, in the peripheral arteries. So really, it's a one of its kind disease because we haven't encountered this kind of a viral infection that can create health complications across all age groups in different parts of the body. And therefore, for a COVID positive patient, running these blood inflammation markers, there are 7 or 8 of them, are important, right? So we want to gauge the risk level for a COVID positive patient to be at risk for these various multi-organ diseases that can occur from COVID. And therefore, those are something that if a clinician asks for, I would not ignore, and I would get done as a one-time basis. Again, in some cases, depending on the results, there may be a follow-up required on a few of these inflammation markers for subsequent months post the COVID infection as well. The one other difference, which I didn't mention in this wave of COVID and related to these inflammation markers, is that this second wave of COVID in India seems to have a far longer tail. And what do I mean by that? So in the first wave, we saw that there were a lot of asymptomatic positives. And even those who had symptoms typically had symptoms for a day or two, right? So you would hear your driver coming back from the village and you would run an antibody test for the driver and driver would be antibody positive. And the driver would say, "Arey, मेरे को COVID कभी हुआ? मेरे को तो पता ही नहीं चला. हाँ, शायद एक दिन बुखार आया था." So you typically hear that now I remember one day I got fever when I was in my village, and but I didn't have any other symptoms or complications. So COVID came and went very quickly in these patients. Symptoms were moderate, didn't last for long, and people tested negative after 8 or 10 days of being positive. This time around, it's different. The symptoms are lasting far longer. People complain of headaches, body ache, lethargy, weakness for a few months, even after getting COVID. So people who had COVID in early March are still complaining of these symptoms today. And people aren't turning negative that quickly. So even after, if you test on day 12, day 14 of getting tested, getting marked positive initially, one continues to remain positive. So I have a friend who's appointed a cook who used to work with Karan Johar, and that before getting that cook into the house, they tested the cook and the cook was positive. And they keep testing the cook every few days because they say, we have no one at home now to make food for us. And today is day 16 and the cook is still positive. And so they can't get the cook back home. So you're hearing more and more stories like this of people, who have this long tail COVID. What it means clinically in the long run, we don't really know. We don't have enough evidence. But this is a new trend that we're seeing, and therefore these inflammation markers are important to run. So just so that we make sure that there's no multi-organ disease resulting from these long tail COVIDs. Coming to some testing statistics. So, when COVID came in this wave or this wall of testing in early March, testing zoomed up. And in our lab, we went from doing about 700-800 tests a day to more than 2,000 tests a day. In the city of Bombay, Bombay was at about 10,000-12,000 tests a day. That zoomed up to 55 or 57,000 tests a day, I believe, was the highest number reached in Bombay at some point in end March and early April. So it's put tremendous load on the testing labs. Ideally, the split should be more in favor of PCR than antigen. Like I said, PCR is the gold standard. But when deployed at scale, particularly through the BMC wards, antigen testing is also being done in good numbers. And in Bombay, perhaps the split today would be about 50-50 between the two. When this sudden workload came onto labs were unprepared. Like I said, a lot of personnel had been redeployed elsewhere. And we found a situation where labs could not cope with this volume. So you had all the large national lab chains faced with a 2-3 day backlog. The problem was further compounded with the fact that Maharashtra government announced that all offices and factories, if they wanted to continue to function, would need to get PCR tests done for their office workers once every 15 days. So that led to a huge surge of corporate testing demand. And all pre-travel PCR testing was made compulsory. So that compounded to the testing load as well. And suddenly we were in a situation where people who really needed the COVID test, sick people, elderly people, couldn't get it easily. And even if they could get the test, they weren't getting results for 2 or 3 days. So I think it was a bad phase for Bombay to go through. Can't blame the labs. It happened too quickly, too suddenly. And the one point I'd like to make here is right through this process of testing, labs have been faced with the challenge of reducing COVID test prices. So, I'm entitled to complain as a lab provider. But if I take a step back, and not just as a lab provider, but as a citizen of the country, the kind of price controls that are put in place for COVID testing, I think is causing a lot of harm to the way testing is being done in Bombay and across the country. So when COVID was first rolled out, it was rolled out at a price of 4,500. Today, the price is 600 rupees. And you can imagine that there is no test or no lab that has that kind of margin to be able to absorb that kind of a price drop, right? Without taking shortcuts. So then invariably what happens is labs are forced to look at cheaper alternatives for personal protective equipment. Labs are forced to look at cheaper alternatives for the testing kits, which brings down sensitivity of testing. Remember, one missed positive is 406 additional infections today. So using cheap testing kits to bring down costs is not the answer. Labs will not employ the number of personnel that would be needed to scale up testing to meet the demand that's coming their way today. Okay, so we understand that we know no lab wants to profit from the current situation, but these price caps that exist in PCR, in antigen tests used to be at 1,500 rupees. Today it's 300 rupees. And CT scans are rate capped as well. So the moment you do that and don't leave it to the market forces of supply and demand, invariably that will hamper the ability of labs to scale up testing and continue to offer highest quality of services, whatever India's hallmark in these last 12 months or so of COVID. So that's food for thought. A lot of representation has been made to the government to lift the price caps and let the market figure it out. There will always be low-cost providers, medium-range cost providers, and high-cost service providers who provide great service or other value-added service features. The other quick couple of points I want to make, and then we can open it up to questions, is the new kinds of tests that are available in the market today, right? So in the Western world, saliva tests are now approved for COVID testing. Imagine how much simpler it would be to do a saliva test as opposed to doing a nasal swab or an oral swab. In fact, with saliva tests in the Western world, there are also self-administered tests which are now approved. So if we could, in India, fast-track approvals of self-administered testing, imagine the scale at which testing could be increased. Today, one of the biggest barriers to testing is not just the processing capacity of the lab, it's the challenge of going corner to corner and collecting a sample. It requires a qualified technician wearing a PPE to go corner to corner to collect a sample. Now, if a patient could collect that sample at home as a home-based saliva test and drop it off at a lab, the same way a urine sample or a stool sample is dropped off at a lab today after a patient collects it at home. Imagine being able to do that for a COVID sample. That would boost the ability of labs to scale up significantly. And again, this is something that the government has kind of been dragging its feet on for approvals. ICMR has been dragging its feet on. So a fast track approval process here, we've made representations as an industry body to the government to do that. I think that will make a big difference. There are some point of care PCR tests that are also being rolled out now, where in less than 30 minutes, you're able to get a PCR test result. So this is not antigen, it's PCR, same sensitivity of PCR, you can get a result in 30 minutes. Obviously, it comes at a higher cost. And again, the government has kind of been dragging its feet on this, and there's no clarity on whether or not that test can be made available widely in India. But it would be a great value add in emergency care settings to be able to do a 30-minute PCR, including for emergency last-minute travel. The other big challenge with labs today, and I'm sure many of you are not aware about this, is every sample that we test for COVID comes with a huge amount of data entry workload. So there are about 20 or 25 questions that you fill out on your form when we collect a sample. And all of that needs to be manually fed into an ICMR portal with every sample that we collect. So for labs that are running a few thousand samples a day, they need to employ 40 to 50 data entry operators working around the clock. This is very inefficient. And again, when we look at in the context of the rate caps, the pressures of working with BMC, and now this data entry challenge, all of it is adding up to not really creating a conducive atmosphere for labs to scale up testing. So again, this is a representation we've made to ICMR that data entry needs to be simplified. What are they doing with all this data? We don't ever see it coming out into the public domain. We don't see studies being published. A lot of the questions are not really relevant today. They were relevant in the first wave when we didn't know enough about COVID, but a bunch of questions they're asking us to fill out today are not so relevant, okay? So again, this is a dialogue we're having with ICMR and the government to make things simpler for labs, so labs can invest in additional testing capacity. Yeah, I think that's pretty much all I had. The last point I wanted to make was
it's loose. But that's the style of wearing a shirt.
Please on mute, Rajiv. Bela Kapoor, Rajiv Kapoor, please be on mute.
The last point I'd like to make here is, a lot of the samples that have been collected in the second wave, how do we know that there are mutations that are prevalent out there? So we sequence these samples, okay? When I say we, the government of India is sequencing these samples. So for every positive, let's say 100 positive samples that are reported as positive in our lab today, the government randomly asks us to send 10 to 15 samples to NIV in Pune to do a whole genome sequencing on these samples. And when you do a whole genome sequencing, we're able to identify the different variants or mutations of the virus that are floating around out there. In the UK, every third positive sample is sequenced. In India, it's probably, I would say, less than 0.5% of all the positive samples are undergoing genetic sequencing today. Okay, this needs to change. Private laboratories like ours also have the capability of doing genetic sequencing. And I wish the government would open this up to enable sequencing to happen on all positive samples. And for that data to be published and be made widely available. So pharma companies, drug regulators can work on building better vaccines, can work on building drugs that can work against these mutations. Till we don't publish the data, we can't have a cure. Okay, and the government has overcome the fear of publishing data about positive cases. I think we have to now cross that hurdle of being able to publish the different types of variations of the virus or mutations of the virus that are out there today. And the only way that can happen is by opening up genomic sequencing in a large way for all positive COVID PCR cases. I'd also like to conclude by saying, I think that the government, and I know more about the BMC than the central government, has done a phenomenal job during these times, right? It's very easy to criticize the government, but you look at the scale of the problem and the way they've managed quarantine, the way they've traced positive cases without harassing people, without creating an environment of fear, I think has been quite remarkable. But the point remains that the journey is long and there's lots to do. So resting on our laurels of what's been done so far today, like we saw in Jan and Feb, becoming complacent is dangerous. And we will have to continue to be on top of our game. We'll have to continue to be one step ahead of the virus. We'll have to continue to invest in availability of critical supplies, drugs, medications, keep doctors on standby, keep critical infrastructure on standby, and the world is ready to help us. You see today, Anita mentioned just before I spoke on how the world is coming forward on helping India. Everyone wants to help India. So we have to ask for that help, and we have to take whatever help is given to us. So as long as we have that outlook and we continue to realize and recognize that this is a dangerous beast that will be there ahead of us for months and years to come, I think we should be okay. If we take a step back and take it easy, either at an individual level or at a government level, then there's further trouble to deal with ahead, and hopefully we don't have to encounter that. So with that, I'm happy to answer any questions that any of the members may have.
Okay, go to your own. Yeah, any questions?
Yes, can I ask, please?
Yeah, sure. Who's this? Alka. Yeah. Yeah, Alka, ask, please.
Okay, Rahil.
Hi.
No, hi. My domestic health tested positive about 12 days back. And before that, he had 3 days of fever. Thereafter, we shifted him to a COVID facility where he had fever, nothing. And after 12 days, they had sent him back today without an rt-pcr. They said it's not required. He's not shown any symptoms and he's fine. So I still need to do. What is the protocol I should follow when he comes home today?
So this is a good question. Do you need to test a positive patient again at the end of quarantine before allowing the person to, get out of quarantine? And there are mixed opinions. BMC says no. Okay, that after a 10-day quarantine, particularly if the person is asymptomatic, you don't need to test again. Personally, I feel that for peace of mind, there is, why would you not get a test done? It's easily available. It's quick, cheap. The testing backlog that labs were faced with has now been streamlined. So for peace of mind, I would do it. But I think the scientific evidence suggests that you don't necessarily need to.
Rahil, Vinod Michandani here.
Okay, incidentally, his CT value was 16.
Oh, sorry, go ahead.
One moment.
Go ahead, Alka.
Can I just finish?
Yeah,
Yes.
sure, Alka. Please finish.
His CT value was 16.
Yeah, so CT value, I think let me spend a minute clarifying on CT value.
The
right?
CT value at 16.
Yeah, so a lot of people get very alarmed with now CT value is inversely proportional to the transmissibility of the virus. Okay, so lower means more transmissible. It does not mean more severe or more virulent. There's a difference. So the cutoff value for CT, after which we detect someone as mark someone as negative, is 35. ICMR says anyone with a CT value of over 35 is negative, below 35 is positive. And CT value can be as low as 10, 11, 12, doesn't matter. But it is not an indicator of how sick the person is. It's an indicator of how contagious the person is. Okay, so at a CT value of 16, one would imagine that person is highly contagious and therefore probably at an early stage of the infection cycle. Just logically, because you're more likely to be contagious at an earlier stage of the infection cycle. When you have a higher CT value is above 30, it's safe to assume that the person is not so contagious and probably towards the end of the infection cycle. But these are all theoretical. Again, we don't know. There's a lot of variation from person to person. There's a lot of variation from mutation to mutation of the virus. So my feeling is even a CT value of 34, I would still consider the patient as positive and take all measures for quarantine. The moment the patient is negative, then you're in the clear. Particularly after a quarantine, right? So a person being negative at the time of having symptoms, I would say that potentially the viral load is maybe not developed to the level where the test can detect it. So retest after 2 or 3 days. But a person who is negative after 10 or 12 days of quarantine and has no symptoms, that person is then fully safe and the negative result can be relied on.
So I should do an rt-pcr and see what is the CT value today.
Yeah, if it's negative, there's no CT value, right? So in all probability, it would be negative by now.
But Rahil, there's a practical problem. PMC
Yeah.
will not test. If you do the test now, after 12 days, it turns out to be positive, society will push him out. The BMC will not take him in. And so what's the practical solution to this?
Yeah, I mean, I think that for all practical purposes, the percentage of people who test positive after a 12-day quarantine right, are very low. So the likelihood is less. B, if it does happen, now some BMC centers like NSI Dome allows private labs to go and test those who are quarantined in Dome. So perhaps you test them 1 or 2 days before they're due for a discharge. Okay. Some other quarantine centers don't allow it. So there's no uniformity in policy on this. My baby maid was at a quarantine center where they didn't allow our technician to go and test her before she was discharged. So we had to test her after she was discharged. But in some quarantine centers, I have family friends who have, house help quarantined at NSI Dome, and I'm able to send our technicians every day and test them. So if you can test them in the quarantine center, great.
Now he's come home. So what do we do now? What is the practical solution? He's come home. And I have a mother who's 90 years old, I myself.
So the practical solution is to test him. In all likelihood, he's negative, and till that result comes for a few hours to keep him away from the rest of the family. Okay. And in the unlikely scenario that he is positive, he needs to be reported to BMC again, right? And the process starts. So it's like I said, a tricky one. One could argue it either way. When testing capacity was short and availability was a challenge, I would say, the second test can be done away with. But today, when tests are again widely available, I would do it for peace of mind.
Vinod, you had a question?
Yes, thank you, Rahil, for that very easy to understand and user-friendly presentation. My question is around testing at a center like yours or home testing. Have you seen any particular trends or differences in the results that come from either of these two sources? And the second myth that often we hear is that if you go to a testing center, you may likely to catch something. And what is your views on that? That as well. Thank you.
Yeah, so to answer the first question, no, there's no difference in, I would say, in the test result, characteristics of the test results, whether you test at home or test in the center. Right. I think the only difference is if you test in the center, you're likely to get your results faster because the transit time for the sample to reach the lab is shorter. Given that we have a bunch of rounds going from the different labs where we collect samples to the main processing lab. In terms of the second question, it's no different, I think, from going to any public place, right? Today, if you go to any public place, you need to follow all social distancing norms. You need to wear a mask. You need to be safe. The infection, there's enough evidence now globally to suggest the infection does not pass through surface transmission. Okay, so going to a medical center and sitting on a chair where a COVID patient positive has sat on a few minutes before, or touching a reception counter where a COVID positive patient may have touched, is not a likely form of transmission for the virus. The most likely form is being in close proximity to someone who transmits through airborne particles, right? Droplets transmission, as they say. So it could be someone sneezing, it could be someone talking, and any kind of saliva transmission or airborne transmission creates a danger. So the way to insulate against that risk is having a good mask, either a double mask if you're not using an N95, or to have an N95 mask. Personally, I don't think that it increases the risk to go to a center to do a test, because typically the people who come to a center to test anyway are people who are looking to go back to work, are people who are looking to travel, are people who are looking to get admitted to a hospital for a minor procedure, right? So acutely sick patients or high-risk patients anyway don't end up coming to the center. They can't. So our technicians end up going to their houses. So there's a natural differentiation created in the population of a home test versus a walk-in test. Right. And if that person is willing to travel or go through an airport, they shouldn't have a problem coming to a center for a test.
Thank you.
Yeah. Any other questions?
Can I ask one question?
Who's that? Geeta, yes, sure.
Geeta Parekh.
Yes, Geeta, sure.
Yeah. Hi, Rahil. I'm Geeta Parekh here. Yeah, just wanted to know what steps should to be followed for returning house staff. We have quarantined in hotel for 11 days. Now he's back in on 5th day, the result was negative. And now we are quarantining in our premises. We have a room there. So now should I be test him again? How many days and we should test again?
No, so you said he was already negative, right? In one of the results.
He was negative on the 5th, 6th day after he came back from his gown.
Okay, I see. Okay, so he was never positive. I see. Okay.
No.
again, this is a good question. We get it a lot. What protocol should be followed for someone coming in from out of town? And typically we say that, let's assume that the last point of contact is where the person picked up an infection, which was the travel route that the person used to come back, right? And in an upper limit, it may take 4 or 5 days for the infection for the viral load to build up, where it can be picked up in a test. So my recommendation is to do an antibody test at the time of the person returning. So you can see whether the person was exposed to the virus, and that gives some comfort that, they've finished COVID. But given that people are getting reinfected again, after the person comes back, quarantine for 5 days, tests on the 5th day. If that result is negative, then for all practical purposes, the person is safe.
So I should just do antibody test.
Antibody at the time of returning and a PCR test 5 days post-quarantine.
Okay. Okay. Thank you. Thank you very much.
Let me share that these are perspectives being shared by a testing lab. So do consult your clinician before you act on these recommendations. I can only share from the framework of what we are seeing as a testing provider, and we are not treating or managing COVID patients. So little disclaimer that.
Any other questions?
Yeah, Bonjour, can I ask a question?
Yes, Jamshid, please go ahead.
Yeah, hi Rahil. Thanks for the excellent presentation. I just had a question. You mentioned that now in the current circumstances, with the load on the labs, sometimes it takes 24 hours from the time the sample is collected till the time the sample comes to your lab. And then sometimes it takes another 2 or 3 days for the sample to be run on your equipment to process the result. Does that in any way, that time lag of maybe from 6 hours to 2 or 3 days, affect the quality of the result?
So a few things here. Today, I think most labs have now got their act together and they're back to a 24-hour cycle. Okay, so that backlog that existed, which was resulting in a 2 or 3 day processing time, at least in Bombay, has been streamlined. I think you call any good lab in Bombay, including ours, you get a result same day, max to max 24 hours. Now, in terms of whether a long transit time or a long time to process a sample affects the result, no. As long as a good cold chain is maintained, which all good labs would do, and the sample is stored correctly in the lab, the sample can be run even after a month, and that's not an issue, but it needs to be stored correctly.
Thank you.
Anybody else?
Coming? Yeah. First of all, I must compliment. Can you hear me?
No. Yes, of
yes.
Course, really.
Yeah, fine. I must compliment the club for very befitting talk at the time when the city is suffering in a big way. Too medically, I must tell you that this is a condition which has come up like for the first time, and therefore certain things would be missing and people will be able to pick it up and write or put it controversially only after a little passage of time. And I think Nilesh Bhai, our member, must be very happy for his son giving an authoritative talk on the subject. Thank you.
I'd like to say something.
Please, Geeta. You're on mute, Geeta.
Hello. Yeah.
Geeta, you're on mute.
I just want to say that,
sorry.
What Shirish Bhai said, that NM has really risen to the occasion. They started all this as soon as this COVID crisis have come. And they have increased the number of tests that they are doing. They are doing home visits. And I must compliment them for doing this as best as it can be done. Good.
Thank you, Varsha. If there are no other questions, are there any other questions?
Can I just ask?
Can I ask one question, please?
Who's this?
Geeta Parikh.
Yes, Geeta. Yes, Geeta.
Yeah.
Please.
What guidelines and precautions to be taken by houses that it is now airborne? So what can we?
No, so the biggest precaution you can take is to restrict the number of people coming into your house and going out of the house. Right?
Yeah, that, yes.
That everyone has to follow what is being asked for in the city today, which is to practice social distancing as much as possible. And when things open up again, to continue to follow all precautions in the building, when you go up and down wearing a mask, when you go to office wearing a mask, you know, if you have people coming in from out, they should be wearing a mask. That's the best we can do.
Okay, thank you very much.
Rahil, can I ask a question, please?
Who's
Sure.
this? Yeah.
Alkambo.
Yeah, Alka.
Yeah, what is the 617 variant which has come? Is it showing up in the tests?
It can only be detected, like I said, through a genomic sequencing. We have no access to that data because that's being done only by a few government labs in the country.
So there.
Can you share your contact number? Maybe we have some more questions to ask you.
Yeah, sure. That's not a problem. I'll do that with Bojor after the call,
Yes.
after the
Yes.
Zoom meeting.
What measures to be taken by recovered patient, and how when can they take the vaccine? After how many months or days?
That's a question again better addressed by a treating clinician than by a testing lab. But I think the only insight I have here is someone who is currently COVID positive should not take the vaccine.
Yeah, and then and how many months, after months or days, they can take the?
I'm not sure. It's something that really, you should check with your family doctor.
Ideally, whatever I know about, it's about 4 weeks. You have to wait at least minimum 4 weeks before you take vaccination post-COVID infection. But you would again check with your physician. But it says 4 weeks.
Okay, thank you very much. Yeah.
Rahil, one more question.
Yeah, sure.
After how many days of the second dose of vaccine should we do the antibodies test?
I think 2 to 3 weeks is a good time to do it. And I would do the antibody test a couple of weeks after the second dose, and then follow it up after a few months just to see the trend of the antibodies, whether they're increasing, decreasing, where we are.
Okay. Thank you.
Okay. If there are no further questions, can I ask Vinod to propose a vote of thanks, please?
Thank you, President-elect John Nariman, Rotarians, Rotarian hands, distinguished guests, and of course, our own Rotarian, Mr. Nilesh Mehta. Thank you. And our distinguished speaker for today, Rahil Shah. We not only feel privileged at the Rotary Club of Bombay Midtown to have this fantastic presentation, but really at a time like when Dr. Shirish alerted us again, at a time when the city and the country is going through such crisis, to have such a not only informative, but easy to understand presentation. Often at presentations, you have questions at the end, but I think in this presentations, we began with questions. And I think, Rahil, with your succinct overview and detailed explanations, it leaves all of us feeling very much comforted that we certainly have not only the right information, but an in-house resource at the Rotary Club of Bombay Midtown. I think all of us have used services at some point in time, but at these crises is when really one thinks of them. So I would like to take this opportunity to not only thank you, Rahil, Nilesh Bhai, but also each of your team members who are working and striving so hard, and really what we call as COVID warriors and frontliners, going door to door or collecting samples and risking their own lives to, of course, with as much protection as you provide, to provide the wonderful service. So with that, on a very happy note, Rahil, we're extremely delighted. We would love to see you more often. Nilesh Bhai, you have to bring him to our meetings and also look at being a Rotarian in the due course. I think with that, I'd like to also thank the TRF committee, Akil, for reminding us the importance of the Paul Harris Fellows, and Dr. Kasbekar for the Little Hearts project, which is definitely in everybody's heart, big or little. On that concluding remarks, I'd like to once again thank Rahil, and please join me in applauding Rahil for this wonderful presentation. I wouldn't want to stand between lunch and you, but in this case, I wouldn't want to stand between you and your next test. So happy testing, and thank you, NM Medical Center, Nilesh Bhai and Rahil, for this wonderful afternoon. Thank you.